The purpose of treating lipid disorders is to reduce the development of cardiovascular disease. Statin is the preferred lipid-lowering medication before adding ezetimibe and a PCSK9 monoclonal antibody. Before starting a patient on a statin, ask yourself if this is for primary or secondary prevention. For primary prevention, consider statin if the patient has any of the following: LDL greater than or equal to 190, age greater than or equal to 40 with diabetes, age 40 to 75 and LDL between 70 to 190 without diabetes, but has an estimated 10-year risk of ASCVD of at least greater than 7.5%. You must have an LDL goal when starting and monitoring a patient on statin therapy. An LDL goal of less than 100 is recommended for primary prevention in a patient with moderate risk. An LDL goal of less than 70 is recommended for primary prevention in a patient with high risk. Consider a high-intensity statin for secondary prevention if a patient has an established clinical atherosclerotic disease, such as acute coronary syndrome, stable angina, arterial revascularization, for example, coronary artery bypass surgery, and stroke. In patients who are very high risk, such as recent acute coronary syndrome within the past 12 months, history of myocardial infarction or ischemic stroke, and symptomatic peripheral arterial disease, the LDL goal is less than 55. A 36-year-old male healthy patient is here to discuss his lipid panel result. His total cholesterol is 200, LDL 150, HDL 53, and triglyceride is 180. What do you recommend for this patient? Since he has no atherosclerotic disease, the question focuses on primary prevention. His LDL is below 190, he is not diabetic, and he has a low 10-year risk of ASCVD, therefore, statin is not recommended. A 50-year-old male patient is in your clinic after he was hospitalized for myocardial infarction. His total cholesterol is 200, LDL 150, HDL 53, and triglyceride is 180. What do you recommend for this patient? Since he has an established ASCVD, a high-intensity statin is recommended.